Good morning, everybody. My name is Connor Shea. I work the Division of Neurotherapeutics and Neurostimulation at Mass General Hospital, the Department of Psychiatry, and my PI, my advisor, was Dr. Thilo Deckersbach. And the title of my talk will be The Dorsolateral Prefrontal Cortex Activity During an Episodic Memory Task Predicts Response to Treatment in a Bipolar-1 Cohort. And as people have told me, there are a lot of words in that title, so I will break that down for you in the next few minutes. All right, so a little bit about bipolar disorder. Estimates suggest that bipolar disorder affects 1 in 40 American adults, about 2.5% of the population. And it's characterized by symptom. So the bipolar means there's kind of two poles of symptom activity. So the first is mania, which is characterized by impulsive behavior, high energy states, decreased need for sleep, and people are actually more likely to commit harmful activities that like excessive gambling, excessive need for sexual contact, that actually could be quite dangerous. On the opposite end is dysthymia, which is the clinical word for depression, which is characterized in the opposite sense by increased need for sleep, low energy states, but also thoughts of worthlessness and increased risk of suicide. And then somewhere in the middle there is euthymia, which is basically the clinical word for normal. However, work in both my lab and in the existing field of knowledge suggests that even when people are quote-unquote normal or euthymic, there are also a series of cognitive deficits that people experience, which are associated with deficits in being able to focus your attention and maintain attention, deficits in planning and other higher-order executive functioning roles, and then also for the purposes of my talk, the most important would be episodic memory. So if you were here for previous talks, you know that episodic memory is the ability to encode basically events and how they happen in time, and that is one of the cognitive deficits we see in bipolar disorder. And when we're trying to treat bipolar disorder, the first line of defense is pharmacotherapy. So you got mood stabilizers and antidepressants. But we find that actually those treatments fail to bring patients to sustained remission. So they'll be on the medicine, and then they'll go off of it when they think they're better, and then it'll come right back. But the research suggests that when you combine pharmacotherapy with some sort of psychotherapy, for example, cognitive behavioral therapy or supportive psychotherapy, two of the most common, you actually can get to sustained remission. But there's kind of a catch-22 because, like I said, even when people are quote-unquote normal, they have memory deficits, which leads to the question, how can they be remembering what is happening in therapy, right? And then how are they going to remember to implement the strategies that their psychologists or psychiatrists are actually telling them in the therapy sessions? So we had two kind of aims for this research. Number one, previous work in my lab investigated the functional neuroanatomy of what these memory impairments might look like in bipolar adults, and we're looking to replicate those findings. He used another imaging modality which involves radioactive collection of samples called PET. We're using functional magnetic resonance imaging, which is from a safety perspective, I don't have any radiation, so decreased risk of cancer and other diseases, but also from an imaging perspective, has a higher temporal resolution, so you can actually investigate higher order temporal structures much more readily with fMRI. But then the second clinical question is our prediction. Do activation patterns across the memory tasks that we ran our subjects through actually predict how well they'll do? And the CVLT is the California Verbal Learning Task, which is a task of episodic memory. So study procedures. Number one, they underwent baseline clinical and neuropsychological assessment. So they were characterizing the extent of their bipolar symptoms, and then in the neuropsych, they were assessing their baseline episodic memory ability, at least from a behavioral level. We will also investigate it from a neural level. Secondly, they underwent fMRI scanning. Third, they were randomized to either CBT or supportive psychotherapy SP, and patients were informed of their randomization because we couldn't really hide it from them because they are two totally different, basically, therapies. And the reason we picked these two was because we hypothesized that CBT would require more memory because it has a lot of, basically, cognitive restructuring or rethinking the way we approach situations in the therapy sessions. So you'd have to remember those techniques to actually improve your daily functioning, whereas supportive psychotherapy is basically more focused on just empathy, so there's less requirement to actually remember kind of tasks that you were learning in the therapy. And then finally, they underwent 18 sessions over 20 weeks of their therapy that they were randomized to. The first 16 sessions occurred weekly, and the last 2 occurred biweekly for a 20-week session. And they were assessed both clinically and neuropsychologically, at before the treatment, and then halfway through, so week 9, and then post-treatment week 20. And we were specifically looking at post versus pre-treatment scores. So here's the task we ran. The first was a fixation condition, so they're just lying in the scanner and they're looking up at a cross. So basically no task, basically baseline activity for that person. The second was an unrelated condition where they were encoding lists of words, but we told them that they couldn't actually be linked through any sort of categorical information. The reason we were using this categorical linkage versus non was because there's a region of the brain, the DLPFC, that seems to be really important in actually underlying the maintenance and manipulation of information. So the restructuring of the words by a category would actually be performed by the DLPFC. So that's why we have these two conditions. And in the directed condition, as I'm alluding to, we told them that they could actually group these words into their respective categories, and we asked them to do so. So fixation, no task. Unrelated, memory task, but no use of any clustering techniques. And 3, memory plus clustering techniques. Just some behavioral information to assess for any confounding that could have happened based on unimportant clinical factors. They were basically matched on age, sex, and education. Age and sex because there are basically different clinical courses across sex and age, and then different memory differences. People's memory declines as they age. And then because this is a verbal task, the ability to remember words will actually depend on whether you recognize those words. So by years of education, they were matched. And then the baseline depression score for these people was 20.6, which means they were in acute depression. Okay, so just to talk about some of the results. In terms of the replication, seeing these behavioral results, we actually didn't replicate any of these. So these are basically some of the information broken down. So the total words, directed list, unrelated list, those are the number of words they were able to recall. And we see that it's generally less for the bipolar group across each of the lists. Most obviously for the total, but that wasn't totally significant. It approached significance, but not as significant as you might expect. And then in terms of their ability to actually group the words in the directed condition, there was actually no difference. And then that serial clustering was generally just like basically a task control. So you can also group words in the order that they're presented, but it ended up not being very important because those scores are normalized between 0 and 1, 0 meaning no usage, so they basically didn't use that task. And from a neural perspective, let's just break this down. So on the left are the brains of all the bipolar subjects averaged together and their activity. And on the right is for the normal controls. Basically, the pictures of the brains are showing areas of high activation across the 3 conditions. And underneath that are the graphs which actually extract out the numbers that actually correspond to making those plots. So basically, over here, you see the fixation, and then the unrelated, and then the directed. So we're actually looking at that trajectory, and that's what's important here. So in the trajectory, we see very little difference in trajectory, and actually in the DLPFC activity, the numbers are actually very similar. So when you're doing this modeling, you can ask questions, are these numbers different? They're not, but the trajectory here is the clinical important question. We see there's no difference in the actual clinical basically presentation of their performance during this task. The 2 graphs correspond to basically I extracted these values at the basically peak task activation in the bipolar, and that's on the left. So that's that set of voxels. And then on the right is for where the activity was highest in the normal controls. But basically, regardless of where we actually took these values from, you saw no difference. There's another region of the brain which basically previous talks have talked about, which is generally important for episodic memory, and that is the hippocampus. And what we're seeing, again, in the trend of where how basically the values change in time, there's no difference, although you can see basically there's a condition effect, or basically a group effect. So the 2 trajectories are different than each other in their number, but the important question is how that changes across the conditions, and it's the same, basically parallel trajectory. So again, no difference in that regard. Okay, so for the second question, the clinically important question, can we use the activation patterns across these conditions to actually predict how well people will do? And the good news is yes, we can. So on the left, basically this is a regression. So we were trying to see if we input basically the people's change in depression scores over time, does that actually predict activity in a certain area of the brain? And on the left there, you can see that there's actually parts of the brain in the DLPFC that are better explained by the change in scores. So there actually is some correlation between greater change in scores and greater activity across conditions. And then I just basically extracted some of the values from a certain region of the DLPFC, and you can see that basically there's a weak positive correlation. Just in terms of methodological concerns, where you actually extract those values actually will make an impact on the correlation you're going to observe. So I know that right here you're seeing basically a weak positive correlation that isn't significant, but it's very hard in terms of one study to actually localize areas of high correlation and also measure that effect size. But I did just want to show you an example of one such correlation and say this might suggest that this might be the lower limit of the correlation you'd see. So it would most likely be this level or higher, which is good. And then also in the hippocampus, that other area involved in memory, we also see the correlation that's, again, weakly positive, but could be even greater. Okay, so in total, we were not able to replicate the findings from my lab previously and other work in terms of there was no difference in the brain activity across the groups in terms of that trajectory, and there were no basically behavioral differences between the subjects, but basically the regions of interest that we hypothesized would be good predictors of how well people would do to treatment were in fact good predictors of treatment. So that suggests that in therapy, before someone is randomized to one of these therapies, you could actually complete one of these neuropsychological assessments and then assess, this person has this level of memory. If it's good levels of memory at baseline, they don't need extra encoding assistance. But if they do have this memory impairment, you might want to include the therapy a bunch of redundancies to make sure that people are actually getting the information and are able to practice it in their everyday lives. So many thanks to my PI, Dr. Deckersbach, all the friends and family who have helped me throughout this process, people in the lab that I work at that trained me with fMRI analysis. I was a novice to this 2 years ago, and also, most importantly, the participants that helped us learn so much about memory impairments and bipolar disorder. Thank you. Any questions? Paul?
Do you think the inability to replicate the previous study in that same lab is due to having used PET before and fMRI now?
It is possible. We assessed that. Or there's no real way to statistically assess that, but I tend to doubt it because there's generally good convergence, although there are some examples, some canonical examples where PET and fMRI would find different things. It is theoretically possible, but it's probably more likely due to, you got a different sample. He had a smaller sample, so we have more power, but still actually low power. So I know I said we weren't able to replicate the findings, but if I go back to some of the behavioral results, there's always the question about, how much do you rely on the statistics and how much do you rely on your base sense? If you're looking at the actual amount of words that are remembered, you will see that it is lower for the bipolar subjects across, which is what you'd expect just based on statistics and the number of people you have. You don't want to reject it at the 0.05 level. But there is some impairment. The semantic clustering I was kind of shocked at. So that my PI specifically was doing the work on that ability to group and how that might mitigate your ability to remember these words. And it was like pretty much exactly the same. So I was kind of shocked because he showed actually large differences in ability to do that. But the good news is in terms of a framework, he saw differences in brain activity mirrored with differences in behavioral ability to actually do this clustering, and then we saw no differences in brain activity and no differences in terms of that ability. So in terms of understanding the relationship between brain and behavior, at least it's consistent. If you didn't see any differences, you would expect similar brain activity, and that's what we saw. Andre?
So can you control bipolar disorder with intense either cognitive therapy or psychotherapy without meds?
Connor, last question. The efficacy is reduced because basically I think what the understanding is that you have the meds basically bringing you to a sort of normal range, and then the psychotherapy helping you to manage with individual variations day to day. So basically most people are on the meds and then they adjunct some psychotherapy. Great. Thanks so much.